Hi everyone, good day. I'm Dr. Tan. I'm from UKM Hospital Chancellor Tuanku Mukris. So today I'm going to share with you a topic on sepsis, resuscitation or replenish. So let me share with you what is the definition of sepsis, which consists of life-threatening organ dysfunction due to dysregulated whole response and also infection. So these three components actually define the current sepsis concept. So the life-threatening organ dysfunction can be assessed by SOFA score, mSOFA, and also qSOFA. However, the dysregulated whole response, the most familiar one is the SIRS criteria, which is systemic inflammatory response syndrome, and there's other syndrome as well. And also the infection can be the bacteria, fungus, prion, virus, and parasite in origin. So the concept of sepsis management, it consists of two parts, which is the systemic resuscitation and cellular replenishment. As you know, usually what we do is that we will restore the stroke volume, we will control the systemic vascular resistance, and also the cardiac contractility to be optimized. And also we will supply oxygen to replenish the cellular need, as well as the hormone replacement and ATP and glucose and feeding. So these two part of the resuscitation replenish, actually, which come first? So let me share with you a basic concept of some resuscitation and shock. For this slide, actually, I'll try to showcase to you what is the resuscitation concept. So it usually is based on trauma and cardiac model. The trauma and cardiac model usually is due to an acute insult to the body and causing, such as like in trauma, you have hemorrhagic and also the cardiac MI, which is a cardiogenic shock, and immediately affect the circulatory shock and later on lead to cellular shock. The circulatory shock actually need to be attend first and aim for a rapid restoration of circulatory failure to near normal vital sign so that we can salvage the cell and not lead to a cellular shock. Usually this event is more to acute event, but however, vice versa, for a patient with sepsis, usually it comes from a chronic infection and later develop into sepsis. They are usually critical ill. And when the patient is from infection develop into sepsis, usually they start with cellular shock, which is due to the energy depletions and because the energy was used to combat the infection and caused high demand of energy and low reserve exhaustion, and also the hormone exhaustion caused derangement and exhaustion and slowly caused the circulatory shock. The circulatory shock in the septic shock is totally different from the circulatory shock from the trauma and cardiac. That's why this event is a gradual event, and we should tackle the cellular shock first before we tackle the circulatory shock. Okay, why we cannot attend the circulatory shock first? Because if we want to tackle the circulatory shock, actually we sometimes will give more fluid and then we will give inotropes or vasopressor. This kind of resuscitation gesture actually will fasten the ATP depletion because the medication need ATP to work and cause the cell to contract, especially vascular wall. And this and also the inotrope make the heart contract more and hyperdynamic circulation and make the ATP faster depletion and cause the cellular shock more severe. And this is a vicious cycle. That's why we need to tackle the cellular shock first before we tackle the circulatory shock. That's why a septic shock is a gradatory event rather than an acute event. So compare head to head, you see this is a trauma and this is a sepsis. You can see the paradoxical difference from the circulatory shock and cellular shock compared with the cellular shock first in sepsis and then lead to the circulatory shock. That's why I call it as a gradatory shock. So point number one, sepsis is a gradatory shock. So it's a gradatory process and it's a slow process due to the chronic infection, and usually patient need higher substrate consumption to mount the adequate inflammation and immunity to fight the infection. However, the sepsis patient usually presented with mixture of sometimes they loss of appetite, they couldn't eat, they come in with some starvation, dehydration, and later on malnutrition. That's why the resuscitation effort, I put an inverted comma here, is because we want to talk about this is not a resuscitation, but in fact, this is a replenishment plan. That's why oral feeding for all the sepsis patients should be initiated as soon as possible, especially less than 72 hours. Point two, sepsis treatment mainly rely on nutrition reserve. Sepsis, especially without shock, usually occur in the adequate nutrition reserve and immunocompetent patient. They will only need some supportive management and source control treatment, such as like debridement for the infected wound and also antimicrobial, which is suitable for the infection itself. And usually they will recover with minimum support. However, this is a basic concept, some basic sciences that I would like to share with you, because sepsis is mainly talking about the organ failure. But before we want to talk about organ failure, we need to know that why the organ failed. Definitely is because the organ didn't meet their requirement of the field to supply to maintain the organ function. So now you see, there is muscle. Muscle, usually they use glucose or glycogen in muscle when we are in an active exercise or we are in sepsis. We use a lot of glucose and glycogen to maintain the muscle vitality. However, in a resting time, we use fatty acid and ketone. But for the liver only use ketone. They don't use glucose, even though in sepsis, they only use ketone itself. So ketone is the main fuel for the liver. However, for the kidney, it's very different. They only use glucose rather than other substrate, except there's some part of kidney will use lactate. So glucose is the main fuel for kidney. And also the glucose and ketone for the brain rather than other substrate. And also the heart, they mainly rely on fatty acid, but fatty acid need to be carried by the albumin to carry it to the heart. Some part of the heart will sometimes use some ketone and lactate as their fuel. That's why with this understanding, you will see that if a patient with sepsis, usually it's a sugar problem first, later patient have using the ketone as the second fuel, and the third one will be free fatty acid. That's why the organ failure started with the muscle, the kidney, which is the first organ that we see failing, and the second part, which is the liver, because the ketones start to deplete, and third, the heart, which is the fatty acid also depletion. So the brain is the last part that we're going to fail. So with this basic concept, we will see that the need of the glucose and the need of the ketone and free fatty acid is so essential for each organ resuscitation. That's why nutrients play a very important role in sepsis. So, and one more I want to highlight is that the serum glucose doesn't equal to cellular glucose, meaning that the cell glucose is not equal to the serum glucose that you measure in the glucometer or in the blood. The serum glucose doesn't reflect the cellular glucose level. Why? Because the cellular level of glucose is heavily dependent on insulin level and insulin sensitive, which usually derange after a prolonged sepsis. Usually, patient will have exhaustion of insulin, and later on, when the late sepsis, the insulin is insensitive. Let me show you some diagram to understand this. Okay, for a normal physiological condition, starving or fasting, usually our sugar level in the blood is normal. The sugar here is normal, and our ketone will be high because we fasting and the sugar slowly come down. The cell shows that some of the glucose is a bit lower normal range, because in fasting situation, patient have lower normal level of glucose, then the body will start to have ketogenesis to increase the ketone to supply the cell energy, so that this is a part of the physiology changes. Glucose, then ketone will go up, and the ketone will be the second fuel to replace the glucose, and later on fatty acid will be increased to replace the ketone for the longer use of energy sustainability in a normal fasting and starving patient. Early sepsis in a well-nourished patient usually is in a hyperinflammatory state because they are well-nourished, they have more energy to spend to fight the disease. So you can see the glucose level here. The glucose in the bloodstream usually will be high due to the catecholamine and cortisol high in the early sepsis. And subsequently, the glucose high will trigger the insulin level high and cause the insulin to push the sugar into the cell, because the cell need a lot of glucose to produce ATP to fight the infection. And however, in this time also, because of patient maybe have some hypoxia, then because of the glucose in the cell is okay, is enough, so that's why the lactate can be formed, and become a more high lactate. You will see a lot of patients with hypoxia, well-nourished patient, usually the lactate is high due to anaerobic situation, due to anaerobic metabolism, and the lactate will be transported back to the liver and recycle back to the glucose again. This cycle will be continues on. Due to the high insulin, also the ketone won't be produced, because ketone, when there's low insulin, ketone only will produce. Yeah, and also high sugar, the liver won't increase the ketogenesis as well. For the next scenario, in a prolonged sepsis patient, usually patient already long time, and then they pass through a few days, maybe 1 week, 2 weeks. This patient, maybe there is present of some starvation, malnourished, and metabolic syndrome, especially those who are obesity patient. They will have this situation, or liver failure patient, they have no reserve. They will present with hypoinflammatory situation. Yeah, prolonged sepsis or hypoinflammatory situation. Usually the cortisol level, catecholamine level, and insulin level will be low because of the catabolism that unable to patient to produce more hormone. Patient really in exhaustion, not enough nutrition to produce this. So you can see the sugar usually in the bloodstream is a bit normal range. It's like that's 3 to 8 like that. So, but this glucose unable to transport into the cell because there is a low insulin, and also there's an insulin insensitive. So the glucose in the cell actually is lower than the actual inside the serum. Remember, we unable to we check the dextrose state. Actually, the glucose level is inside the blood. We couldn't measure the cellular level of glucose content because we have no machine to measure. So we don't know how much actually the cell has glucose level. Actually usually is much more lower than the bloodstream. Problem is that now when the glucose is low in the patient with hypoxia, definitely the lactate will low, because the lactate substrate is come from the pyruvate that is going through the anabolic metabolism and slowly convert to lactate. However, in a hypoxia patient, not enough substrate to convert to lactate. Lactate definitely low. So in this situation, patient need to produce a lot of ketone to sustain the life. Okay, that's why when a patient with late sepsis or prolonged sepsis, the ketone in the blood usually will be high. The ketone is come from gluconeogenesis, ketogenesis from the fatty acid. Yeah, and also the fatty acid also will be low if patient already sick for some time, and because of depletion of fatty acid, all this ketone also coming down. So all this vicious cycle is always happen in a prolonged sepsis. So summary: when a patient with early sepsis in a well-nourished patient, in hyperinflammatory state, patient with serum glucose usually high, and also the lactate high due to hypoxia if patient have hypoperfusion or hypoxia, and also normal or slight elevated ketone. However, in a prolonged sepsis or patient sepsis in starving, malnourished, or metabolic syndrome or liver failure patient, the glucose level in the serum will appear normal and low, and actually lactate will be low or near normal in the bloodstream because of, I told you, there is no pyruvate to convert into lactate in the hypoxic condition, and ketone will be high. We couldn't measure the cellular glucose level, yeah, because we couldn't find, we don't have any machine to measure that. So point number 3, if you have suspect the insulin insensitive, okay, why we need to know that it's insulin insensitive is because if the serum patient unable to regulate glucose properly, the serum insulin insensitive definitely will affect the patient's cellular glucose utilization. So when we suspect, how we suspect this is insulin sensitive in the situation whereby your glucose level is more than 10, even with or without DM disease, or after receive a bolus of glucose, patient glucose level is shoot up without any normalization after hours. Patient with metabolic syndrome usually have this insulin sensitive. Patient with diabetic mellitus, and patient have a persistent high ketone more than 0.5 and persistent hyperglycemia. So this you have to suspect they are insulin insensitive. Why we need to know that? We need to give insulin. Yeah. For patient, point number 4. For the patient with sepsis and septic shock can be hyper or hypoinflammation. Hyperinflammation usually is come with a usually early state. Patient have well reserved, then patient have cytokine storm. Okay, the cytokine over production and cause hyperinflammation. In a patient with prolonged sepsis, usually patient will enter into the hypoinflammation state. I can call this like a human inflammation hibernation state, yeah, or fatigue state. So when patient with hypoinflammation, usually the patient's body will conserve the energy to prolong the life rather than to fight the disease, and until they want to prolong as far as possible their life, right, by using to conserve the ATP. Usually hypoinflammatory is due to exhaustion of ATP after prolonged inflammation, and this usually happens in a very subtle manner and over a period of time, usually days and weeks. So you can see from this chart, patient will come with hyperinflammation. Later on, they will go in, if let's say they come with multiple time of infection or prolonged infection, they will go into a very hyperinflammation side. This hyperinflammation usually see in the category 4 and category 5 patient in COVID. Yeah. So and in point number 5, patient with hyperinflammatory septic shock, we will see that a patient, because of cytokine storm, usually we will comply with our survival sepsis campaign guideline. Usually we start with antibiotic, fluid vasopressor, target MAP more than 65, and you might need to suppress the cytokine storm by high dose Dexa or Metoprep. And also you can start with anti-leukin or control source control, and also antimicrobial, anti-thrombosis, and also early feeding and albumin, good glycemic control. This is a very conventional way of approach. So septic shock with hyperinflammation, you can use both together, which is resuscitation and replenishment at the same time. However, for a patient with hyperinflammation, we are aiming to delay the resuscitation, but more to replenishment. Why? Because this hyperinflammation septic shock usually is like a gradually process. Patient actually is ATP depletion. ATP depression need to slowly rejuvenate, replenish, you see. If without the ATP in the cell, if we start all the resuscitation process, like we suddenly give a bolus of fluid, suddenly make the heart is pumping very well, because it adapt to the low BP, they are pumping very well. Suddenly you give a bolus of fluid and then suddenly the heart become big, and the heart cannot contract because low ATP, and then you cause the ATP consumption faster. Even sometimes you start inotrope vasopressor that cause the vasoconstriction. Vasoconstriction need ATP as well. So without the replenishment, we start all this medication, actually we fasten the process of ATP depletion and actually harm patient more. So that's why in this type of patient, we do not use BP as a target treatment, because I have some cases in my hand, patient with BP of 70/40 for 2 weeks, but patient still conscious, alert, no symptom at all, no organ failure. This is true. That's why I say maybe you have to look into this part of we replenish the patient slowly without targeting a good BP, because mainly the organ failure is not because of BP low, rather than the organ failure is due to depletion of the ATP. And as just I told you, the kidney need sugar, the liver only need ketone. That's why we need to replenish all this substrate to make the organ failure recovered. Yeah. So in a patient with low ATP also, the vasodilatation itself is due to the lack of vascular tone rather than cytokine cause the vasodilatation. So both end also can give you vasodilatation. That's why don't confuse, thought that the vasodilatation must be a cytokine storm. No, it is not. So we slowly replenish the patient, slowly give the glucose, slowly give some insulin and early feeding. Actually, patient BP will pick up eventually. Yeah. And hypoinflammatory septic shock management usually is more to like personalized management, early feeding, good glycemic control, supply, and also the low dosing of steroid replace the adrenal deficiency, and also source control, antithrombosis definitely needed, and albumin replacement. You remember the albumin is needed to transport the lipid to the heart, yeah, and also a lot of pharmacodynamic that need albumin to be a carrier, as well as a lot of mineral need albumin to be carrier. So hypoinflammatory septic shock management also, the fluid management should be rehydrate strategy rather than a boluses. So sometimes intermittent small boluses will need it only. And vasopressor and inotrope may be fasten the ATP utilization, as I said, right? And also you may start a low dose or delay the low dose of vasopressor while patient replenishment already started. Replenish may start with glucose boluses and insulin infusion via early oral, or we start the oral feeding as soon as possible in ED. For me, I usually start the early feeding by less than 6 hours when the patient is in ED, and patient is much more stable usually. Yeah. So based on this concept, you see cellular shock is come from dysfunction of cellular function. So the cellular function maintained by ATP. The ATP itself can be divided into 3 groups, which is the oxygenation, the substrate, and also mineral. These 3 can contribute to the ATP and so for maintain the cellular function. So I use this diagram to make a simple approach to sepsis with hypoinflammation, especially those who need replenishment. So conventionally, we know that the oxygen, the substrate, the mineral, the oxygen usually is using our survival sepsis campaign. They already tell you that replacement of fluid, start antibiotic, give fluid boluses, maintain the cardiac output, maintain a systemic vascular resistance by vasopressor, give oxygen, transfuse. This is the conventional way of doing the resuscitation. This is everybody know. And also the mineral replacement, anything low we replace because mineral need for the cell to function. Yeah. But this substrate part usually we are missing. You see the glucose, the ketone, the lipid, we usually don't much of pay attention. But I think this is much more important in our resuscitation. Yeah. And these two parts I call it a cellular replenishment rather than a resuscitation because we take it slowly. Yeah. So for the oxygen resuscitation, usually we will give, as conventional, we know already, we will give all this resuscitation protocol, we give our one bundle, focus or fluid and oncotic. But remember, this resuscitation should be delayed a bit when the patient is hypoinflammation because they need time to replenish their ATP before they can take this, they can only take this resuscitation protocol easily, because if not, we will cause a catastrophic vicious cycle. Yeah. So this one I'm not going to talk more because everybody know how to maintain the blood volume. Yeah. Pump, fluid, pipe problem. How about mineral? Mineral, definitely everybody will top up. You see phosphate low, magnesium low, you will top up, right? So this is for the maintain the cellular function. This is utmost important. For the substrate wise, you have to look into the glucose, pyruvate, and ketone and lipid. For me, these three is more than enough. And also we need to look into the hormone replacement, cortisol, thyroxine, adrenaline, glucagon, ADH, and vasopressin. But I know this is a bit more extensive, but insulin and cortisol, I think we can play around it with the vitamin, which is a thiamine, which is more important for cellular replenishment, sorry. So for the essential part, these four things we need to replace in the emergency. But I know that the ketone lipid is so hard to replace. You know where to find the source. Very simple. A simple milk, a milk will give you all these nutrients. Yeah. If couldn't, you just advise the patient, if patient can tolerate orally, you just tell them to eat normal meal with eggs, carbo, and some rice with oil, some good oil, then we'll do. And then we need to give the thiamine as soon as possible, and we need to control the sugar with insulin and also glucose and replace the cortisol. So how to manage the substrate management in patient critical ill? So I suggest this is what I do in my own department here. I do it. So how I control the sugar and how I maintain the glucose always enter the cell. Yeah, make sure the ATP always there. So what I do is that when the serum glucose is maintained, I try to maintain 8 to 12 at all time. And serum glucose, if more than 10 or higher, I start insulin infusion. And for serum glucose less than 8, I may consider boluses of dextrose 50%, 50 ml if the patient BP low, or we will give a dextrose 10 to maintain, as a maintenance, or to start oral feeding to target 8 ml per millimole. Start oral feeding. The dextrose boluses may repeat as many times as possible if you need it, but this is for more to the hypotension patient. For the patient with no hypotension, usually I will give D10 to maintain it. And then we need to start the insulin infusion as soon as possible in this type of case where we suspect patients suffer insulin insensitive, especially in obesity patient, in the metabolic syndrome or liver failure patient. Remember, this is like a power cocktail, a power bank for the cell. You see, you need insulin and glucose together, only the sugar can go into the cell. So if you don't have insulin, but you only give glucose, the cell will not able to take out the glucose. And the false alarm is that when the lactate low, because of the glucose low in the cell, it doesn't reflect the patient is getting better. Actually, patient getting worse because reserve is low. So this is a pitfall that I want to highlight. Yeah. So take home message: septic shock is a gradually shock, and sepsis patient usually presented with mixture of starvation, dehydration, and malnutrition. And all sepsis strategy are gradual. All sepsis stages are gradually occurred over a period of time and week before patient present to hospital. That's why I say this is a gradually shock. So septic shock can consist of all 4 types of shock, which is volume depletion, hypovolemic shock, cardiogenic shock, distributive shock, and also obstructive shock. And also sepsis also, remember, early sepsis come with in a well-nourished patient is usually more the hyperinflammation. So this is indicated by glucose high, lactate high, normal or slightly elevated ketone. Prolonged sepsis or sepsis in starvation, malnourished or metabolic syndrome patient, in hypoinflammatory patient, usually the glucose is low or normal, lactate will be low or normal, and ketone is high. So hyperinflammatory septic shock, resuscitate and replenish together as soon as possible. But for the patient with hypoinflammatory septic shock, or we call it ATP shock or respiratory shock, replenishment first, and later on slowly resuscitate. So thank you. Hope you enjoy this lecture, and any questions, you can contact me with following website, our website, www.mysepsis.org, and this is my Twitter and this is my email. Thank you very much.